Hello, everybody, and welcome to our PrecisCa tumor board on multiple myeloma. Very excited about these cases and our panel. I'm Dan Pollier from the University of Colorado, and I'm joined by a really great group of colleagues here today to discuss these cases. And so each of us is going to introduce ourselves, starting with Dr. David Schuster.
Hi, I'm David Schuster. I am a radiologist and nuclear medicine physician from Emory University.
Hi, I'm Dr. Peter Forsberg. I'm a medical oncologist with a specialty in multiple myeloma at the University of Colorado.
Hi, my name is Ajay Nuka. I'm an associate professor at the Emory University Winship Cancer Institute. I specialize in multiple myeloma.
Our first case is a 66-year-old Caucasian female who was diagnosed with an ISS stage 1 multiple myeloma in 2011. She was originally treated with bortezomib and radiation, and this was followed by autologous stem cell transplant. And in the aftermath of this, she had a very good partial response. She is now undergoing treatment with lenalidomide and dexamethasone, and this has been complicated by thrombocytopenia, which has required treatment interruption. So the main question we're going to get to here is whether she should continue the lenalidomide or ultimately switch treatment. So let's go through this in a little bit more detail. The patient originally presented with a pulled muscle in August of 2011, and this manifested with intense pain radiating to the left posterior ribs. And this was not responsive to pain medication and steroids. Now, I know, as you all who are experts in multiple myeloma, these symptoms probably give different alarm bells than perhaps a primary care physician would. And we know in this case, this patient ultimately does end up getting diagnosed with multiple myeloma. But Dr. Forsberg, maybe you can just tell us, do you feel like there is a classic clinical presentation of this disease? I understand that I'm sure many times it can be very heterogeneous, but are there things or elements that you see in a pattern-like situation with patients?
Yeah, as you mentioned, it can be pretty diverse, but the most common symptoms are musculoskeletal pain. I think it's in the range of 80% of patients with myeloma have bony involvement at diagnosis. So the most common symptom people present with is pain. But as you mentioned, it's often pain that may mimic much more common scenarios. Back pain is a common chronic symptom or issue people may deal with. So often it leads to some delay in the diagnosis. Beyond pain, the most common other symptoms are more general, fatigue, sort of more broad, feeling that something is not going well for some amount of time prior to diagnosis. Beyond that, some of the more classical crab type symptoms, symptoms that are associated with, anemia or hypercalcemia tend to be, I guess a little less common that people have truly symptomatic hypercalcemia or other things, although it certainly can be a pretty pronounced circumstance when it does present that way. So, not all patients come with all the, all the indicators of myeloma. Often we're dealing with things that are, maybe more broadly systemic, and often pain that's been a longer term or sort of a subacute issue that may be the most common scenarios we deal with.
Great, thanks. That's really helpful. Despite the symptoms, the patient was noted to, in this case, have a performance status of 0. More into this patient's history, she had hypertension, some chronic kidney disease with a baseline creatinine of 1.7, and how related this is or was to her myeloma is a bit unclear. Type 2 diabetes, diabetic neuropathy, Crohn's disease, Hashimoto's thyroiditis, and a possible DVT-PE in the long past. This is a non-smoker who rarely drinks alcohol, and no hematologic malignancies in the family. And this is maybe a good time in the first case, Dr. Nuka, to just pause on that because I know in my field of myeloid malignancies, we've been appreciating more the family history component of these diseases, and even identified some genes that are inherited. Anything like that in multiple myeloma, or when you do your history on a new patient, anything you're looking for in the family history per se.
Right. So that's a great question, and this is one of the most common questions that we get asked in the clinic. Number one, is it hereditary? The answer that commonly is given, it is not hereditary. Having said that, for unknown reasons, the patients with immediate family members that have a family history of multiple myeloma have a higher risk. The odds ratios are significantly higher for developing multiple myeloma, but these are never beyond the 1.5 to 2 odds ratio, which is the risk compared to a general population is close to 1.5 to 2 times the odds of having multiple myeloma for themselves. So there is no specific genes. There are several Jiva studies that have been done specifically to figure out what exactly is driving the myeloma genesis, so to get a better understanding. But so far, there are no huge hits that really would delve us into looking into a specific aspect.
Thank you. So just moving on to this patient's specific oncologic history, September 2011, the imaging showed diffuse extensive osseous lesions involving the spine. These were PET-avid. A biopsy of a T3 paraspinal lesion did reveal a plasma cell neoplasm that was CD138 positive. Bone marrow biopsy was performed showing 25% plasma cells, and therefore this patient was staged as an ISS stage 1, Dury-Salmon stage 3 due to extensive bone disease, normal cytogenetics, and a monoclonal protein of 2.8 grams per deciliter with an IgG level of 2,973. And Dr. Forsberg, would you mind, just to put us in the right frame context for the cases in the future, would you mind just describing these different staging systems of myeloma and how you use them?
Yeah, so there's a few different staging systems we use in multiple myeloma. They're different than staging systems in other types of cancer. That's another question that often comes up when patients meet with us for the first time. What stage is my myeloma? And unlike other diseases where stage has really profound impact on where disease is, in myeloma it's more attempts to measure aggressiveness and maybe get a sense for prognostic information about how myeloma may behave in the future. So the different staging systems we use at times include the ISS, the revised ISS, and the Dury-Salmon. At this point, the Dury-Salmon is a bit more of a historical staging system. It was the first staging system that was developed now more than 30 years ago to describe behavior of myeloma, and it had more to do with organ involvement and extent of disease. So there are sometimes dyssynchrony between it and more modern staging systems like the ISS, the International Staging System, or the revised ISS. The International Staging System, the ISS, includes just 2 variables, albumin and beta-2 microglobulin. And using those 2 variables, we're able to get a pretty substantial amount of information about potential behavior of myeloma over time. The revised ISS is a way to try to combine that ISS with other prognostically meaningful tools, including cytogenetics and LDH. And so it puts all 3 of those together to create one score. And when you're trying to understand how myeloma may behave over time, especially at diagnosis, they're important tools to help describe patients who may have a more indolent or more aggressive course, although a large portion of patients are left in a more middle ground territory. So it can be helpful, but I think we always learn more beyond that over time. But in terms of identifying patients who are most likely to have very aggressive or maybe sometimes more indolent courses, they're useful tools in that regard.
Great, that's really helpful. Thanks, Dr. Forsberg. So this patient subsequently initiated treatment with bortezomib. This was 2011, had some focal radiotherapy for palliative purposes. And then after a couple months, the bortezomib was held due to an upper respiratory infection, pneumonia, and diarrhea. This patient then proceeded to an autologous stem cell transplant, had a very good partial response. As a maintenance therapy in the post-transplant setting, November 2012, the patient was initiated on lenalidomide, appropriately dose-reduced because of the renal dysfunction with dexamethasone. Aspirin was given for DVT prophylaxis. And then really just after the first month of this maintenance therapy, the lenalidomide had to be held initially for 2 weeks due to thrombocytopenia with a platelet count of less than 30,000. So the main question here, Dr. Nuka, I'd love to get your thoughts on is, how do we manage this? Do we switch therapies? Do we change the dosing? Do we increase the interval of time off lenalidomide? Or is this not of concern? How would you manage this specific issue with the cytopenias in the lenalidomide?
Right. This is a great question to start with, but I think whenever I'm making a decision at this point of time, I'd like to go through the entire history of where she came in and see where exactly we found the gaps. Like in terms of the question that I always have is like, is this thrombocytopenia really a medication related, or could this be the disease related? That is the biggest concern that I have, which always leads me going back to the original story that the patient has. So this is a lady who has a lower risk ISS staging, as you heard from Dr. Forsberg clearly, that the due to Salmon stage is clearly an extent of the disease that the patient has. That means if a patient is diagnosed later, they obviously fall into a higher stage instead of falling into a lower stage if the patient is diagnosed early. So when you look closely from a prognostic standpoint, this patient has ISS stage 1 and normal cytogenetics, which means this is the patient that should do very well compared to all other myeloma patients, because all myeloma patients are not the same. But we're seeing the exact opposite here. At 1 month after starting maintenance, she's starting to go down on the platelets, really questioning where exactly the disease process is at this point. So going back to her story, so she got started in October, and then she got bortezomib, which is a single agent that she got, which was in 2011, absolutely yes, that was an acceptable induction treatment. And once she was stabilized with the radiation, she got bortezomib only for 2 months. And then she had a lot of infectious process that went on, upper respiratory tract infection, pneumonia, that led to the stoppage of the treatment. So now we know it much, much better, so that by using some prophylaxis earlier on, you can continue these treatments without having to stop these treatments for infectious reasons. So antibacterial prophylaxis are very much an essential part in the initial treatment process for multiple myeloma, because the patients are significantly immunosuppressed because of the active myeloma that is probably keeping them, not making them adequate immune competent. So now she got only 2 cycles from what we see with bortezomib. That is a suboptimal treatment for somebody who has a symptomatic multiple myeloma. So now taking this a step back. So she had 6 months of treatment after she got the infectious process that she did not receive any treatment. So unfortunately, it is very unclear what happens to the natural history of the multiple myeloma with suboptimal treatment. So then she got the transplant. Fortunately, she got a VGPR. Then a month later, so 3 months after the transplant, she started the maintenance, and a month later, her platelets are less than 30,000 with lenalidomide and dexamethasone. 2 things to focus on here with this story. Lenalidomide and dexamethasone steroid is not the most usual combination treatment that we give during the maintenance at this time, but absolutely in 2011, that is something that I'm thinking in the back of my mind. Number 2, lenalidomide dexamethasone was a relapse regimen that is usually used in the time point when the patient received. So it's a relapse regimen, and a maintenance regimen was the question that I have at this point. So number 2, in the same context, so when somebody gets a transplant, 3 months later, everybody gets the staging workup, and she was put on she was put on a lenalidomide dexamethasone regimen. Let's assume that she has this was a maintenance regimen. So let's look at all the maintenance trials that we have in that space using lenalidomide. So we have at least 4 trials from 4 different continents using lenalidomide in that specific trial, now cementing more cementing the value of maintenance more to prolong the PFS. So none of these trials had shown the thrombocytopenia to be a higher grade within the first month of the lenalidomide initiation. So yes, you see the grade 3, grade 4 toxicities in the range of around 10%. To make it more clear, grade 3 thrombocytopenia is less than 50,000 platelets, and grade 4 is less than 25,000. In her case, it's a grade 3 thrombocytopenia. It is highly unlikely to expect with lenalidomide. And the first thing that I want to make sure is whether this is disease-related or the drug-related. And with all the story that is falling right in place, if this is all the drug-related, the first, we can hold off the drug and look at the kinetics of the platelets, whether the platelets improve. If the platelets are improving, I make the first dose reduction to see whether that dose reduction is able to make the patient to hold on to her platelets. So you asked a small question, I gave a long answer.
Well, that's really useful information. So it sounds like, your main concern in this case is, that this is less likely a drug-related phenomenon and possibly related to the disease recurrence or progression. And so that would be your first move would be to check for the status of the disease. And Dr. Forsberg, can you tell us, when you do dose reduce lenalidomide for cytopenias, do you have a particular percentage that you dose reduce, or what sort of levels do you go down?
Yeah, so it's a good question. And this patient is a specific scenario, although not an uncommon one necessarily, in that they have baseline chronic kidney disease. We don't exactly know what their serum creatinine was or GFR prior to initiation of the maintenance, but if it's in the realm of what it was prior to treatment, we know this is a patient with sort of a stage 3-ish CKD. And so, those are patients where in the post-transplant maintenance setting, in the non-post-transplant maintenance setting, you're going to need to dose adjust to avoid our main toxicities. And among the main toxicities that we do deal with lenalidomide, it includes myelosuppression. And I think that myelosuppression tends to be a little more pronounced in the post-transplant setting as well. We don't know about this patient what their pre-treatment platelets were in the recovery from the transplant, if they had a really sufficient platelet recovery, or if they had kind of an insufficient or more modest one, which is something we sometimes see. But usually, if we were to have started this patient on something like 5 milligrams of lenalidomide because of the baseline renal function, you may be thinking about a reduction even to 2.5. Sort of the dose I generally start with in the post-transplant setting when there is normal renal function is 10 milligrams. Different trials had slightly different structures. Dr. Nuka mentioned the, really robust evidence we have supporting maintenance lenalidomide from several different large phase 3 trials that have now been aggregated into meta-analyses that help to support the, sort of impact of this as a tool. But there are some slight differences between those trials in terms of dosing structure: 21 days off, 21 days on, 7 days off versus 28 days continuous. I tend to use 21 days and then 7 days off to give patients a bit of a chance to recover. I think that sometimes helps with the myelosuppression. And if you were to start a patient on 10 milligrams, usually my first dose reduction would be to 5 milligrams. But we'd be starting at a potentially lower baseline. And so with the renal insufficiency patients, it can be a little harder to find that right dose, in terms of blood counts, because they may just be a little more fragile and more susceptible to the myelosuppression from the Revlimid.
Great, thank you. So I think in summary for this case, what we learned is that maintenance therapy after autologous stem cell transplant is certainly the standard of care. Lenalidomide is a good tool for this. Lenalidomide can be myelosuppressive. When that does happen, we would typically see that further out in time than in this case. And so the time course of the cytopenias would make a person need to also consider disease progression. But when lenalidomide is to be dose reduced, it can be done based on an actual reduction in the dose or interruptions between treatment cycles to mitigate those cytopenias.